that we can talk about. Since we've got time to fill, we're going to start again over with our overall cycle, and we're just going to talk about just some basics of medication-assisted treatment. I'm going to go through this pretty quickly. Has everybody seen this presentation before? No? Ah, well, you're in for a treat. No, but first, for those of you who are here for Dr. Camiar's talk on neonates and perinatal use of Suboxone, here are some of the references he's got. And I think we can send everybody a copy of this if they want it. Is that right?
Yep.
Okay. So you can get all of these slides if you wish. And right up front will be our references. There's some Mo. Kind of the take-home message is buprenorphine seemed to do a little bit better in terms of methadone for decreasing abstinence syndrome in neonates, but still, both of them are very good. And certainly better than trying to detox women in their first or third trimester, generally considered unsafe. Transitioning from methadone to buprenorphine, maintenance and managing of opiate use disorders during pregnancy, that's a tough one. And that's how you can get a hold of us if you want to have this presentation or these references. So the basics of it, what is it and what do we use it for? So we use it for the old term, which is supposedly not used, but everybody uses it, which is addiction. Substance use disorders is basically what they're called now. Although there are 11 criteria for substance use disorders, you've got to have at least 2, and you can have up to all 11. One of the ways to kind of format that is the 5 C's. It's actually 6 now. Craving, loss of control, compulsive use, use despite consequences, and capricious use. Which one are we missing? Control, compulsion, consequences. No, that's all of them. Craving and capricious. And by capricious use, we mean use in dangerous situations. You're just not very, you're very kind of flippant in your use, and you endanger yourself or others. We view addictions to any of these medications as not acute events, but as chronic, relapsing, usually progressive diseases of the central nervous system. This is due to the fact that drugs will change the functioning of your brain, and if given over a long enough period of time, that change can be enduring, so that even if you withdraw the drug, you still got those brain changes. Your brain does not snap back to the way it was before. And if we think about it, that makes sense. Our brain is designed to change. It's supposed to change. It's supposed to adapt. If it didn't, we would keep putting our hand on the hot stove each and every time. The whole idea of learning something means that there is a change in your central nervous system. And so with the chronic use of drugs, we change our central nervous system in a myriad of different ways, and it will not change back. Now, we can continue changing the brain so that it is better functioning, but it's the old Thomas Wolfe line, you can never go home again. Your brain is not going to be the same after it receives drugs. You're going to have to continue to change your brain forward in order to reestablish some type of functionality. And medications can help with a number of different areas. To kind of bring the point home, let's look at some pretty pictures. Okay, this is cocaine abuse. Now, can they see that when I use a pointer here? Or do I use a pointer here?
Oh, I don't know.
I don't know. But in your top, oh, there we go.
There we go.
Oh,
You can just touch the screen.
okay. So here are our normal subjects. And these are different sections through the brain. Okay, we're actually we're looking up at the brain, but these are sagittal sections across the top, so we can consider it looking down. Here's the front of the brain. There's the back of the brain, left and right. And you'll notice there's a lot of red. Red means very active. Blue means not very active. And so in our normals, we see a lot of frontal lobe activity. We're thinking. We're doing executive functions. We're deciding what to eat, where to drive, how to get around things. We're problem solving. We've got our emotional states here. And our amygdalas are active, doing their emotional thing, and we're seeing stuff. And this is through all different sections of the brain. Now, when we've got somebody who's been using cocaine for a prolonged period of time and they stop, so does their brain. It's used to being highly active, overexcited, and it has downregulated its activity so it can look at some semblance of normal. That's what tolerance is all about, is an adaptation of the brain to these exogenous substances. And now when we remove the exogenous substances, the brain isn't working too well. We're not thinking very well. We're not problem solving. Generally, we're just laying on the couch or in the hospital, and you ask us what's going on, and we say, nothing. We say, what's your emotional state? How are you feeling? And they say, depressed, I don't know. I'm bored. And just in general, these folks aren't thinking very much. How many people have watched people go through stimulant? Although this is cocaine, it's same with amphetamines. How many have seen somebody go through early cocaine withdrawal? Anybody? No? Well, they sit around and they do nothing, and they eat and they sleep, and they look highly depressed, and they say they're bored because nothing stimulates them. They're used to, the only thing that really is able to stimulate them and get them excited is the drug itself. Because the normal things that stimulate us, the sight of our loved ones, a sunrise, a sunset, a good meal, all that's kind of flattened out, and so they're just very drab. Now, these type of issues, if we go 100 days, so this is 3 months out. Okay. And as you can see, it's better than it was, at 10 days out, but it's certainly nothing like it was when they were normal. Before they were using. So we're starting only now, 3 months into this whole process, to begin to see increased activity of the brain. These folks don't problem solve very well, and whatever problem solving skills they've got are very basic. And that's usually how to go back and load the crack pipe, how to go score the drugs. It's not higher order functioning. And so medications that we have can be helpful in terms of at least beginning to restore some of this functioning of the brain, helping to decrease this type of craving. Now this is the same type of thing we were talking about before, only we're looking specifically at the dopamine areas of the brain. And the dopamine areas of the brain are the reward areas. For the purposes of this talk, it's the reward areas of the brain. And you'll notice when we're not using drugs, we get reward. It gets active. There's plenty of dopamine around. We're having a good dopamine response. We're laughing with friends. We're having a good meal. We're having our favorite meal. We're seeing our favorite significant other. This thing can be very active. But when you're a month out, nothing. Nothing excites us. Nothing makes us happy. It's just kind of there. And 4 months post-op, 120 days or post withdrawal, it's only now beginning to have some type of recovery. So this is what we would refer to as a post-acute withdrawal syndrome. This is the type of brain activity you see in somebody who's got post-acute withdrawal. They're anhedonic. They really don't give a damn. They've got real primitive thinking. They just sit around and say, I don't know. They might be very irritable, but they don't feel any reward system unless we introduce the drug. If we introduce the drug, wango, now suddenly they look like this again. So they'll often tell you that the only time I feel normal is when I'm using. And that's absolutely true because their brain has chronically changed. And by chronic, at least for months and months and months. And it may take them, even if they didn't use drugs, maybe a year or more for that brain activity to begin to resemble what it was before. So this is what we're up against. This is why just simply stopping using the drug doesn't necessarily mean that the patient is automatically going to start getting better. It's going to take a prolonged period of time. Rome wasn't built in a day. Okay. Is that the same for all drugs, including alcohol? The answer is yes. There are some differences between the various drugs, but especially in the acute phase, when they've been using for a couple of months. But most of our patients who are going to be coming to us, they've been using for years. And so certainly when it comes to the dopamine issues and the issues of decreased frontal lobe functioning, those are going to be the same no matter what drug you use. Whether it's nicotine, I don't know, have any of you ever quit trying to use nicotine, but you have difficulty concentrating, you don't feel like you're thinking straight, you can get pissed off at the drop of a hat, you can become emotionally labile, and you just don't necessarily think straight for a period of time. So it's going to be the same for all drugs of abuse, including alcohol.
What about taper? Like, so if they're on a stimulant, for example, tapering it like a really slow rate. Like, how does that have a different effect on how?
We don't really have any good studies for that.
Like, if you were to go do a really long taper, would somebody still have adequate dopamine levels to where they have maybe a flat effect, or they could still function and a reward system to the point where?
Well, in some ways, at least with opiates, that's part of what we do with our use of methadone and buprenorphine. With the use of stimulants, sometimes we can get away with using phenylethylamine derivatives that are, basically pharmaceutical grade. Wellbutrin, bupropion is a antidepressant that essentially looks very similar to methamphetamines, and sometimes those can be used. But it's real difficult to use in any of our populations potentially addicting medications and have them taper it appropriately. That's essentially the problem we're talking about that underlies all the use of buprenorphine and methadone. It's how to keep them from overusing it or using it differently. But theoretically, you'd be able to slowly taper it over a prolonged period of time and over months and maybe a year or so, and they may get better. So that's a downside, is it's chronic, often worsening disease that even if you stop using the drug that caused these problems aren't going to go away, not for a prolonged period of time, if ever. But it is treatable. And we got to look at treating the whole person. Just stopping the use of the drug doesn't necessarily equate with recovery. There's a difference between being dry and being sober. Being dry is being abstinent. being sober is having an untroubled abstinence. And that's really what we're shooting for, is untroubled abstinence in these folks. But that's not always easy to do right off the bat, and so medications can be helpful. Treating substance use disorders, I think it's also good to kind of keep in our mind the different approaches that we can have when we treat them. Much of what we're talking about in our populations early on is just harm reduction versus abstinence. For a lot of our folks, especially when it comes to opiates, which are exceedingly difficult to treat, especially if you're using short-acting opiates like heroin over a year's period of time, our standard treatment paradigms simply don't work all that well. That's why methadone was introduced in the 70s with our Vietnam era veterans, because 9 months worth of treatment, we had relapse rates that were sky high even a month after 9 months worth of treatment. So we're looking at harm reduction in a lot of these cases, at least to begin with. Get the needle out of their arm. Decrease the chances that they're going to get bloodborne infections. Keep them from being vectors in the rest of society for infectious diseases of one kind or another. And then consider over a period of time moving into abstinence. But first things first, let's decrease the harm that they're doing to themselves and the rest of society, and give them a chance over months, perhaps years, to develop some skills in behavioral therapies and in self-help support groups to be able to tolerate abstinence as an untroubled way of life. So, in many respects, the use of buprenorphine and methadone and some of our other substances is to allow time for these therapies to take hold over a prolonged period of time before we taper them off the opiates altogether and give them the best chance of remaining abstinent. Although it's not, we don't have a good medical paradigm for it, what is critical in terms of long-term abstinence is finding a meaning and purpose in life. That is critical if these folk are to remain abstinent over a prolonged period of time. Remember, we're taking them away from their favorite friend. We're taking them away from their lover, a jealous lover who's never very good for you, but a lover nonetheless. And that was the meaning of their life for some period of time. So trying to find something that's that can give them that sense of hope that's required for recovery. Address the co-occurring mental disorders, address physical concerns. Most of these folk are tore up from the floor up when they walk in the front door. And because of the issues Emily was talking about, they don't show up for their medical appointments. They often have chronic medical illnesses that go far beyond what an average individual would be able to endure simply because they don't show up for their medical appointments. And this is where medical assisted treatment can be helpful. I'm going to let you read that. There's really not much to it except, yep, these are medications that are FDA approved with a couple of exceptions for the treatment of these disorders, mainly to help with withdrawal symptoms or to prevent cravings. MAT can be helpful with withdrawal for people with it in substance use disorders, and it can help with relapse in terms of cravings. Any questions? Am I going too fast or too slow? No? All right, we'll keep going. Little focus on alcohol here. Benzodiazepines are used to ease symptoms and prevent delirium tremens. That, frankly, is the only reason you need benzodiazepines, is to prevent delirium tremens. If somebody doesn't have a history of delirium tremens, even though they've been through withdrawal a bunch of times, then you really don't need benzos to withdraw these people. There are a number of other medications that you can use to ease their withdrawal symptoms, but they don't necessarily need benzodiazepines. They don't need a controlled substance like Valium. However, if they do have a history of delirium tremens, ain't nothing going to help but benzodiazepines. So that's something to keep in mind. A lot of times, one of the reasons we want to talk about alcohol in relation to opiate use disorders is because the two tend to go hand in hand. In the old days, well, for instance, Charlie Parker, who was a famous saxophonist, who was also an IV heroin addict. His friends always knew when he was trying to get off the heroin, and he would get off heroin for periods of time. But they knew when he was trying to get off heroin because he was living in the bar. The high amounts of alcohol can help prevent opiate withdrawal symptoms. It ain't the greatest, but it's better than nothing. And back in the 30s, that's about all you had was nothing. So it's not unusual for us to see folks' alcohol use disorders increase when they're coming off of opiates. And even when they're on buprenorphine, you'll see increased alcohol use simply because they're trying to find something to change their mood, and that's a similar acting substance. Both of them increase dopamine, and they increase dopamine through similar mechanisms. So you'd expect the two to be used not necessarily interchangeably, but quite often one for the other. So we can use it for withdrawal, but we can also use medications for relapse prevention. Disulfiram, anti-abuse, is our oldest. That's the one that makes you throw up if you drink. And it works by scaring the hell out of people because they don't want to die when they start drinking. And if you've got enough medical problems, you can die if you've been drinking on disulfiram. You can also get drunk if you're on disulfiram. You just have to do two things. Number one is keep drinking. You'll drink and throw up and drink and throw up and drink and throw up. But eventually you will get your blood alcohol level up to where you feel drunk. So you've got to keep at it and not die. If you can do those two things, you can drink while on disulfiram. Now, acamprosate, not used quite as much in this country because it's a TID dosing schedule. You got to take it 3 times a day. But it's helpful to decrease cravings. All of these medications that we use to decrease cravings, with the exception of disulfiram, you have to be on for months. Most of these studies that show efficacy, that show that it works, the patient has had to have been on the medication at least 12 weeks or more before we begin to see recovery rates or non-use rates separate from sugar pills. So you got to be on it a prolonged period of time. And remember, it only helps a little bit. Okay? If you want to get drunk on any of these other medications, you will. But what it can help do is it can help decrease the intensity and the frequency of your cravings to the point where the other tools that you're teaching them might be able to overcome that urge to use. And they say, well, yeah, I had a craving, but I surfed through it like you taught me, and I've noticed they're not coming as often. So these medications can be helpful, but they're not a panacea. They're not a cure-all. So why do we use MAT for alcohol? Well, for withdrawal, we don't want them to die and go into DTs, and we want to increase the odds that the person is going to progress in treatment. It also helps increase therapeutic rapport and compliance. So helping ease somebody through withdrawals, even though it's not going to kill them, can be very helpful. They're much more likely to listen to what the program has to say if they believe the program has helped them so far. And so if you can help relieve some of their withdrawal symptoms with dignity and respect, they're much more likely to listen to what you have to say when you're asking them to do something that's fairly uncomfortable. My old saying is the Marquis de Sade school of detox is rarely helpful in long-term recovery, trying to say that, well, they need to feel the consequences of their actions. In withdrawal states, they already know what the consequences of their actions there's not necessarily a reason for them to feel it. It's not going to change their behavior. And I think it's pretty evident why we want to use medications to help relapse prevention. Now for opiates, once again, there are some potentially addicting medications as well as some potentially non-addicting medications that we can use to help go through withdrawal. The oldest of these non-addictive medications is clonidine. Okay, it's not FDA approved for this, but they've been using it since I had hair, which was probably sometime back in the 60s, which is when the Haight-Ashbury Free Clinic first published its papers on the use of clonidine patches for opiate withdrawal. One of the things that happens in opiate withdrawal, well, one of the things that happens when you use opiates is you decrease your adrenaline output. This is what makes you go on the nod. This is what puts you to sleep. This is what decreases your heart rate. This is what decreases your respiratory drive. And if you use opiates for a long enough period of time, the area of your brain that produces that norepinephrine, the locus coeruleus, overcomes that. And thus you're able to take opiates and drive a car and go to work and go from doctor to doctor to doctor to get more opiates. So you begin to wake up. Well, when you come off the opiate, now suddenly your adrenaline system runs wild. And you get myodriasis, you get the large eyeballs, you get anxiety, you get sweating. You basically get a norepinephrine rush. Okay? And that produces a fairly large amount of the withdrawal symptoms you get with opiate withdrawal. Doesn't take care of the pain factor that goes along with that and some of the gut symptoms, but clonidine decreases your adrenaline output. And so that's one of the things we can use to help decrease symptoms of opiate withdrawal by decreasing your norepinephrine system. The use of clonidine always uses other medications. You often have to give them something for cramps, something for pain, like high doses of ibuprofen, something for GI distress and diarrhea. But the heavy lifter in a non-opiate-based detoxification is going to be clonidine. I've gone to a hand. Methadone is something else that we can use. Once again, a long-acting opiate. It's the first opiate that was used and approved for use by the FDA for chronic use in opiate addicts to prevent withdrawal. These can only be prescribed from FDA-approved clinics. So it's a long, drawn-out regulatory process. The DEA walks into your site all the time and checks your labs and does counts. But it can be very effective, and the VA refers to methadone clinics a lot when people have failed buprenorphine treatment. And it's because it's tightly controlled. You've got to show up every day to start with to get your methadone. If you do well on methadone, however, there are ways that you can get take-homes, okay? And it depends upon how well you're doing. That instead of having to come in every day, you get an extra dose to take on Sunday. And then after so many months, if you're doing well, then you can get another dose for, say, Tuesday. And if you do well for a year's period of time, you can work your way up to monthly take-homes. Now, one of the reasons I like to point this out is that for those of you who are, for instance, going through the methadone training, very seldom do they tell you where and how to begin tapering it. They may tell you how to taper it, but they don't tell you when the patient's ready for tapering. So what type of behavioral milestones can you use to help decide when it's time to come off the opiate? Well, methadone's got one in many respects. And it dovetails nicely with your ASAM criteria. So if you're using ASAM criteria, if you go on the DEA websites and look at what the requirements are to get take-homes, that can begin to give you an idea of what you may want to put into place behaviorally in terms of milestones you can use for when to consider tapering somebody off any of their opiates, including buprenorphine. Any questions about that? So if you don't have a protocol for when and how, at least what should the patient look like before we start taking them off their buprenorphine, check out some of the methadone material. And finally, buprenorphine. Well, one of the knocks on methadone is that there's no ceiling effect. You can overdose and kill yourself on methadone if you take too much of it. You can inject methadone. That's one of the reasons it's very tightly controlled. You can still get loaded on methadone even if you're a long-term opiate addict. Buprenorphine, on the other hand, is a long-acting opiate, but it has a ceiling effect. In other words, if you go over 16 milligrams, you pretty much, with a couple of exceptions, have saturated, in 80% of the cases, every mu opiate receptor in their body, and if they're not responding to 16 milligrams a day, they're probably not going to respond to a higher dose. Now, having said that, I've got a small cadre of my patients who are on 24 milligrams, and some of them even had as high as 36, but those are rare and kind of far between. So between 16 and 24, you're pretty well topped out. And if they don't respond at 16 and 24, they ain't going to respond if they're absorbing it properly. And I think I've just kind of gone through most of the medications we use for relapse prevention, with the exception of naltrexone. Naltrexone is an opiate blocker. It will block opiate receptors. It's really popular in the criminal justice system, which is very much against any type of hedonistic activities whatsoever. And so oftentimes they don't care whether you're doing well on buprenorphine or methadone. They want you off all potentially addicting substances. And the studies definitely show that naltrexone is about at the same level of buprenorphine and methadone in terms of preventing relapse, if you can get the patient on it and keep them on it. Naltrexone does come in a long-acting injectable that can last for about a month, and if you can get them on it for a period of 3 to 4 months, usually they do very well. Let you read this. Again, it's kind of pretty common sense. Why do we want to use these medications? But this last one here gets to the heart of the matter that a lot of the public has got a problem with, and that is that, well, why should we be using opiates for an opiate use disorder? Can we really say that, how can you relapse if you never lapsed? Okay? If you never stopped using opiates, how can you say that you've relapsed when they stop taking your buprenorphine and start using heroin again? And what I basically point out is, let's take a look at some important numbers. 42,000 overdose deaths in 2016. 2.1 million people with opiate use disorders in 2016. And that number has risen between 2016 and 2018. Now, the number of new opiate cases is starting to fall, and that's because people are beginning to shut off the supply of prescription narcotics, and so we're not creating as many new addicts, but we still got the ones around that we had before, the ones who haven't died. And so we've got an incredible number of people dying of these particular overdose of these particular drugs. Now, although when we look at standard drug standard drug treatments in most of our other disorders, 40 to 60% of people, for instance, with alcohol and most drug use disorders will remain abstinent 1 year after treatment. And I can see that question. Let me just finish this idea and then I'll answer it. The problem is that if somebody's been using heroin intravenously for a year, previous studies have shown that after 9 months of treatment, remember these other guys, they got a 30-day spin dry in their local detox center, got sent to AA, and they did fine for up to a year, 40 to 60% of them. In the case of opiates, when we sent them through 30-day treatments and then 90-day residential treatments and then halfway houses and then three-quarter-way houses and then put them in sober recovery living situations and then discharged them back to their home environment. So a total of 9 months of some type of organized treatment, they had a 60% relapse rate in a month. Now that's for IV heroin users. So clearly our standard treatment approaches for when people are using opiates isn't what it is for the rest of the other drugs. And that is our number one reason for using buprenorphine and methadone in this particular section of our addicted population. So there's a question here from David. Can you test UDS, and is it necessary for naltrexone? I mean, can you test UDS for naltrexone? Is that the question? If it is, then it is not a standard test that you can run. You can ask to see if it's GC, do gas chromatography, mass spectroscopy, and see if there's any naltrexone in there. But generally, I don't. If they're not using and their UDS is not positive for drugs of abuse, then I'm assuming they're taking their naltrexone. But it's also one of the major reasons for the use of the long-acting Vivitrol. If I put it in their butt or in their abdomen, I know they got it. But I mean, I suppose, like I said, you can test for it, but normally we don't. It's probably fairly expensive to get a GCMS on, for naltrexone. Haley, you got a question?
I'm raising my hand. Yes, so just on because you're on naltrexone, and I don't have as much understanding of how the dynamics of how it works, but there's some concern about overdose related to dosing with naltrexone in conjunction with illicit drug use on top of that, maybe?
Sure. If I may kind of go through a mindset. Okay, so I'm your IV heroin drug user, and I've been given a get well card from the judge. So I've got to go to treatment, or I'll end up in the big house. So I go to see old Doc Broadhead, who says, what you need, my boy, is to get on Vivitrol. And so I'll detox you from your opiates, and I'll fill your hind end with Vivitrol. But I really don't want to stop using. And like with most addicts, I'm going to tempt fate. I'm going to see if this stuff works. Now, what it's done is it's blocked my mu receptors. But it's only blocked my mu receptors. The delta, the kappa receptors are still very active. And so they can be stimulated. So I start using, I do a test dose of my heroin. Damn, bunk stuff, not working. So then I use a higher dose. And then I use a higher dose. And then I use an excessively high dose. And depending upon the opiate I use, remember, although they have mu effects, they also have effects on, to some degree, on the other opiate receptors of the body. They also have effects on other areas of the body. Some of them, for instance, have an anticholinergic effect. And that's why they've been pulled off the market, because people were having seizures on this stuff. So suddenly, if I start using uber high doses of narcotics trying to get that old high, I might be able to kill myself with an overdose. But it's not an overdose in the normal and typical sense of an opiate overdose. I've overloaded my system with the effects of the drug in other areas, and that is not good, and then I can go into cardiovascular collapse and die. Okay. That's one concern. The other concern is that because I've blocked my mu receptors, they're going to suddenly become hypersensitive over time. And although for the next month I may not use, I now have made my mu receptors hypersensitive, so that when I go back to using, because I walk away from the clinic and say, no, I need to get loaded. A month and a half later, I decide to use again. I'm not only back to square one, I'm even before square one, because I've got very sensitive mu receptors, and I can easily overdose myself that way. Well, again, it depends. Okay, how low is a little dose? Most people don't necessarily use recreationally to see if they can kill themselves, but they kill themselves because they accidentally give them more than what their body's able to tolerate. But they don't have any really good way of judging what their body is able to tolerate at that particular moment in time. All they've got to go on is what they used before, and then try to cut back on that. And sometimes they're good at it, and sometimes they're not. The most dangerous time for an opiate addict is when they've been clean and they relapse. And so there's a question that Vivitrol might somehow make that dangerous portion of it a little bit more dangerous, because of the effect that the drug has had on making their mu receptors hypersensitive. That's a lot of words in a short period of time. Did that answer your question?
That was so awesome. Thank you.
You're welcome.
Yes.
Any other questions, piggyback on that, or anything else? We plow on. I can let you read through this that basically says, yeah, MAT is helpful. It helps decrease criminal rates. It helps decrease rates of infection in the individual. It helps increase abstinence from their particular drug of abuse. Remember, it doesn't necessarily say that they don't switch drugs of abuse. And that's always a problem we end up with when they're in our clinic, is that, especially out here in the West, they stopped using opiates, but now methamphetamine ends up turning up in their urine. So they're, rearranging deck chairs on the Titanic. And that's an entirely new conversation you have to have with them. But for the most part, it's going to help decrease their use of opiates.
Got a question.
Yeah.
I know earlier you mentioned about alcohol withdrawal, and you mentioned that you can prescribe benzodiazepines to treat the tremors and delirium as well. But don't benzodiazepines and alcohol themselves have a significant fatal interaction?
Well, it's if you combine your alcohol and your benzodiazepines.
Yeah, because if you are using benzodiazepines to control the after effects of alcohol withdrawal, right?
Right.
Shouldn't the patient be very careful not to use benzodiazepines even when they're under the effect of alcohol, because it could severely depress your respiratory and cardiovascular system? Well,
that's always when you have somebody on an inpatient basis, that's easy to control for. But when you're trying to do outpatient detoxifications, that's where your sphincter tone goes up, because, I don't control how much alcohol this guy's got in his house. And if he takes 3 Valium and takes a beer and then decides a few more beers to go with a few more Valium is a good thing, you can get an overdose.
So how can you decrease the death rate any preventative measures to prevent that kind of fatal result?
So
can you?
repeat the question. The question goes back to something we were talking about earlier in terms of alcohol and benzodiazepines. And the question is, well, if you're using benzodiazepines to help alcohol withdrawal, isn't that a little dicey? Isn't that a little dangerous? The combination of the two could kill you. And the answer is yes. So how do you prevent that from happening? Well, first of all, remember, the only time you absolutely must use benzodiazepines is when there's a question of delirium tremens. Now, delirium tremens is something that should and must only be handled in the hospital. That's a reason to put somebody in the ICU, is if they have a history of delirium tremens when they go through alcohol withdrawal. That requires hospitalization. So if you're going to be doing outpatient detoxifications from alcohol, the first thing that comes to your mind is, this is not something I said earlier, but because it's not necessarily the gist of it, but since we're talking about it, is that, does this guy have DTs? Yes or no? Yes, the guy has a history of DTs. To the emergency room with you, be gone. Okay, and then they can use benzodiazepines in a controlled setting. Now, if the guy says, no, I shake and I get a little confused and I get a little nauseated, but for the most part, I've done it okay. It just is lousy. I feel lousy for 3 or 4 days. Perfect. Now I can use other medications to help with those withdrawal symptoms, which are non-addictive in nature and won't be additive if they use alcohol on top of it.
Okay.
Okay?
Thank you.
Okay. So again, what can Matt not do? Well, it can't serve as a substitute for other modalities of treatment. And our patients want to do that. Hey, can't I just come and get the meds, doc? Okay. Do I really have to do the psychobabble? Okay. And I laugh at them hysterically and says, yes, you do. Okay. No psychobabble, no good drugs. Okay. You've got to do these things. Okay, you got to do these things. And we're kind of sticklers for that. If they don't show up for their outpatient treatments, they show up to me and I got to play the bad guy and say, no, you're not doing your stuff. I'm going to put you on a clonidine taper. No, wait a second, doc. Okay, back into therapy. So we make, at the VA, we make them go to therapy. And they've got to complete a therapeutic regime and then reevaluate for what else they need if they're going to continue on buprenorphine treatment. Now, if they're a couple of years into it, that's a different matter. By that point in time, we've usually decided that these guys are the forever omas, and they're right where they need to be with their lives. But if they come to me and go, I want to get off the drug, well, then you got to better get back into therapy, because coming off is the time where you're going to need to brush up on all your psychotherapy and your skills in terms of dealing with cravings and how you're going to do negative consequences and how do you do with impulsivity, because you're going to need that coming off the drug, no matter how slow I go. Matt, in the criminal justice system, once again, it works. It helps these guys stay out of jail. As a result, it helps me keep my car because it's not getting stolen in order to pay for heroin. Methadone is the most widely used medication for this purpose in terms of long-term treatment. It's also been around for the longest period of time. As we talked about before, it can only be dispensed from opiate treatment programs that are regulated and can be very helpful if you've got a patient who needs to be highly regulated. If they're not doing well in the MAT program at the VA, we will pay for them to go to a methadone clinic. Buprenorphine has been approved since October 2002, so it's been around for about 17 years now. It's almost of age.
question.
Yeah.
So methadone, you said it's tightly controlled, right?
Yes.
So is one of the main reasons why because of its potency level?
Because it has a high addiction potential, yes. Okay. And because you can overdose on it, and because it has a street value. And remember, it was brought out at a time where the whole idea of using opiates to treat opiates was wildly novel. It was one of those European things that you just didn't do. And so it was only through the use of Department of Defense research that I think really helped push it over the line and get it available to the civilian population over a period of time. It has less abuse, buprenorphine has less abuse potential than methadone and is less likely to result in medically significant harm if misused. Now, I think I'm going to have to take a bit of a step back on that and remember one of the reasons that it's considered less abusable is only the formulation that comes with naloxone on board. Naloxone is like naltrexone. It blocks mu receptors, but it is really, really poorly absorbed through your mouth and through the GI tract. Naloxone is usually what's given intravenously in the emergency room or intranasally. We pound about a metric buttload of this stuff up your nose and absorb it rapidly through an insufflation process. I can get enough of it in you to reverse an overdose. But taking it orally, it's basically not going to be absorbed. So if I combine that medication that's going to block mu receptors with the Suboxone, what it does is it prevents you, well, it doesn't prevent you. What it'll do, if you decided to shoot it up, it would put you immediately into withdrawal because now you've shot up the naloxone. So combining the buprenorphine with the naloxone is what keeps these guys from testing the waters to find out whether they want to shoot up that particular opiate. The Subutex, the pure buprenorphine, can be injected. Again, however, because it has a ceiling effect, most of our addicts won't necessarily try it, but that doesn't prevent those neophytes out there who haven't been using opiates very long from trying that. So Subutex, you can expect, is much more highly diverted because, hey, you can shoot it. And for those of us who've been working with addicts a while, we know they'll shoot anything, they'll give it a try. And so those who are not used to IV opiates, those who are early on in the game, buprenorphine is something you can use and get loaded on, and it will kill your children. Your children can overdose on it. So although it might be safe for your long-term veteran addicts, it ain't safe for your kids or adolescents who are trying it for the first time, especially when they combine it with alcohol. Any questions on any of this? Okay, most of you guys know most of this stuff in any type of training. This kind of goes through the induction phase. The one thing I like to mention about the standardized inductions is honestly, there's more than one way to skin a cat. Have any of you guys had problem trying to get a heroin addict remaining abstinent long enough to go into moderate withdrawal to use a standard induction technique? I have. They go, oh no, I can only go a couple of hours, before I can use, and so they tend to walk away. Well, there's a different way to think about doing that, and that is using very low doses over a 24-hour period of time. For any of you, anybody, just give me a number. What's the longest most of your IV heroin users are able to go without using heroin again? How many hours? Type in, call in, raise your hand, give me a number. I'm trying to get the interactive portion of this thing.
Less than a day, though.
Hmm?
I was in less than a day.
Less than a day. Oh, yeah, it's less than a day.
4 hours.
4 hours, okay? Often because that's the half-life of heroin, is about 4 hours. So these guys, they may go 4, 6, but usually they're shooting about 3 times a day. They'll start to get the sniffles, they'll start to get uncomfortable, and then they'll need to use. Well, uncomfortable, starting to get the sniffles, they know what's coming, and so they're going to use. So in their minds, they can only go 4 to 6 hours. Now, buprenorphine has a 36-hour half-life. But notice what we're doing. Our standard inductions are 4 milligrams, and if they tolerate that, whoop-ah, another 4 milligrams. Well, remember, 16 occupies most of their receptors. So we're doing a whole lot of taking over opiate receptors right away by using buprenorphine. Now, buprenorphine will glom onto those receptors, but it stimulates it a whole lot less than the heroin will. And that's why we have to wait until they're in moderate withdrawal, until they've got a lot of these open receptors before we can give them this mega dose of 4 milligrams of buprenorphine and then give them another mega dose of 8, essentially occupying half their receptors. Well, what happens if we just use 2 milligrams and tell them to use it every 3 hours if they're having withdrawal symptoms? Now, in their mind, they say, you know, I can go 3 hours. Heck, that's less time than I usually use. Okay. And so 3 hours over a 24-hour period of time, how much are they, what's the maximum dose they're able to use? 8 to 12 milligrams. Okay. But we've spaced it out. So what we've done is we've waited 4 hours. Okay, waited 3 hours. Half-life of heroin is gone. We give them just 2 milligrams of the buprenorphine. Wait another 4 hours, more of the heroin's gone, and then we give them another 2 milligrams. Remember, they still got that 2 milligrams on board from 3 hours ago, because that stuff goes nowhere. It's a 36-hour half-life. It hangs around forever. And so it's kind of like slowly backfilling. We wait for some of the drug to go, we put them on a little bit, we wait for a little bit more of the drug to go, we put them on a little bit. So I have no problem in giving 12 milligrams of Suboxone in 2 milligram tablets and having these patients go home and come back the next day. They bring their pill bottle back, I count how many pills they've got, boom, that's the amount that they've used and how comfortable they are the next day. So I've done an induction with them, but I haven't used this particular method for induction. I've used kind of a slower, gentler method. It doesn't work well with long-acting opiates. OxyContin's not going to work all that well with, but for short-acting opiates, it's another way of getting them induced, getting them off their other opiate and onto buprenorphine without withdrawal. Stabilization phase, this is when we're still making adjustments. They're still going through withdrawal symptoms. This can last up to a couple of weeks. Whoops, I've done it. I broke it again. Thank you. And then maintenance phase. Patient's doing well. They're steady on buprenorphine. Our sphincter tone goes down a little bit. They're engaged in therapies. And now I've got a question of how long am I going to keep them on this? I've stabilized them. Am I going to do a withdrawal on them so that I've just transferred them from one opiate to another and I'm going to try to get them off? Or am I going to keep them on it a prolonged period of time? This is probably the biggest question mark in terms of the use of buprenorphine or any of the opiates is what am I going to do with it? It sounds a little gross, but I want to put this in your head. Okay, starting somebody on buprenorphine is like picking your nose. Okay, you want to know what you're going to do with it before you start the whole process. Okay, so I want to know, I want to have in my own mind some idea of how I think this is going to go. This guy's been using for 6 months. He started out with a broken leg. He's now using 80 milligrams of oxycodone a day. He can't stop. He's in college. He's about to fail out. This is somebody I may want to stabilize and then taper while we keep him in outpatient treatment. Versus somebody who's been using for 2 to 3 years and just in the last 6 months they've started using heroin. They haven't been employed in a couple of years. They never finished high school. They're living out back of the Costco, eating out of garbage cans. I'm going to keep this guy on it a long period of time until he has a life that's worth not losing. And then we can consider tapering them off at that point in time. So get a feel for what you're going to do beforehand, and it can be very helpful when you're in the hurly-burly day-to-day, try to figure out your patients coming in. What am I going to do with this guy? To have, at that point in time, beforehand, made a decision about what you think you're going to do with this guy. You can always change your mind as time goes on, but have a good idea where you think this person is going to float in terms of your program before you even do the induction. We've got 10 minutes left. Does anybody have any questions?
Yes. Michael here.
Okay, Mike, hey.
Hey, I saw this presentation previously that you gave. And as per the usual, you present it in a very interesting and entertaining fashion. Thank you for doing such a great job. I've noticed in my patient population, because I'm an oncologist, fortunately, most of the patients are older. And many people with a prior history of drug use will say things to indicate that they felt it would be an entertaining thing to do to use heroin or cocaine, and they would tell me that it was part of the culture of the 1970s, especially the early 70s. Do you find that people are using hard drugs in a recreational fashion like this for the same reasons, or that reasons have changed?
I think they continue to experiment with them for the same reasons. Generally, remember, adolescence is a time of natural psychosis. So it's also a time of experimentation, of trying new stuff, of separating from family of origin and finding a new social group. And so they're going to be the most vulnerable socially. As well as psychologically. They're also the most vulnerable physiologically, because we know exposure to drugs before the brain is completely myelinated, before the frontal lobes are completely myelinated, and that's probably around age 26, that you end up with higher rates of people actually becoming dependent if they started earlier than if they started later. So I think they're doing it for the same reasons. It's the same type of peer pressure. But, we're dealing with millennials, and so how that presents itself is going to be different. But, they're still going to parties, and they're still taking stuff out of mom and dad's cabinet. We used to raid the liquor cabinet. Now they're raiding the medicine cabinet. So I think that's always going to be there. That's endemic in the human condition. But it may just look different to the older, to our older eyes. They're not quite the same as, when back in the day when we were young.
Right.
But
we were much better, of course.
Exactly. But I mean, we'd still do anything if, no matter how crazy it sounded, if it ended with, and then you meet chicks. So
Right.
that hasn't changed it. How to socialize, how to fit in, how to be part of the crowd, how to feel different.
And this business of physicians causing addiction through opiate prescriptions after surgery, hopefully that will decline over time. I know most of my surgical colleagues don't automatically prescribe Percocet after a surgery anymore. But do you see that as a significant cause of addiction in your experience, which is considerable?
Well, it has to do with exposure. Okay, I don't think the physician caused the dependence. Nobody opened up this guy's throat and threw half a bottle of oxycodone down it.
Probably not.
But the more you expose the general population to addicting medications, just playing the odds, 10 to 15% are going to become dependent, and you don't know, starting up in general, which 10 to 15% that's going to be. So the more you expose, the more likely you are to find one of those who has a genetic predisposition and start that whole process. But yeah, the greater we expose the population to substances of abuse, the larger number of folks are going to become dependent upon that. And all you have to do is look at cigarettes and alcohol to see that's historically true. And if you want to trend something, let's watch the percentage of folks who have cannabis use disorders increase as we begin not only to legalize, but to capitalize and to monetize and to expose as many people as we possibly can to cannabis, because it's now become a business. And business wants to expand its base. That's a little editorial, but I'm not ashamed.
I noticed. It's a lot of editorial. That's okay. That's cool. But thank you. Thank you. Because often I think we sometimes are fingered out by the media for being somewhat responsible, which I think is true.
Yeah.
But how responsible are we? I don't know.
We
so
should have
as a
known
radiation
that.
oncologist, hopefully we, we're not giving opiates automatically. And I think that over time, opiate prescriptions from the oncology community has declined substantially. But that's great. Thank you.
My feeling is A, we should have known better, but B, let's make a realistic expectation of this. We're using very powerful and very helpful medications that also can be highly addicting. So let's think about why we're using them, what we're using them for, and what the possible consequences might be. I mean, using it in a case where somebody has got 9 months to live, why worry about this? Okay, but if you've got a 10-year-old, now we've got to worry with a cancer that's got a good prognosis. Now we might want to be a little bit more circumspect about how much, how frequently, and how we're going to help make sure that they don't develop a dependence. There was another question.
Hallie, did you have a question?
I have so many questions all the time, but this is sort of related to what he just asked, and I think I just need to be referred to another group. But a big hurdle we come up against is our chronic pain patients who have the, comorbidity of SUD or history of addiction, and wondering at success rates related to that. I think you guys have a separate group for that, is kind of what I'm asking. Do you have another presentation specific to that?
Yes.
I don't think we've got a...
Yeah, I'll step in here.
Look who it is!
So yeah, we do have another program focused on pain management, where we do talk about alternative therapies for pain management. But on that team, we have a licensed alcohol and drug counselor who talks a lot about that. So I will send you over the info for that.
Troy, I didn't realize you were lurking there in the background.
The man behind the curtain, always.
Are there any other questions? Well, come next time around. We're meeting 2 weeks, correct?
Yes.
Okay. Again, we'll have a presentation, but if you're bored of the presentation, bring a case. Bring questions. Next time we meet, I think I'll be here and I can bring a case of a guy who was on opiates along with 32 milligrams of Xanax a day. And where he is 5 years later and what type of problems we're currently having with him and why.
It's fun.
Great. All right. So that's 2 weeks from today. So July 24th. So I hope to see everybody back then.
All right. Thank you,
Thanks,
everybody.
bye-bye.
Thanks, everybody.
32.
Okay.